Tapish sir, good evening, sir.
Good evening.
Yeah, so we are live, sir. We are going.
Good evening.
A very good evening, everyone, and welcome to No Thrombosis program. No Thrombosis program.
Wait for a minute, huh? I have some problem here, huh?
Yeah, sure. Yes. Sir. Welcome to No Thrombosis program. No Thrombosis program is dedicated for real life challenging cases, discussion specifically. In today's, if you see, all the delegates, because of your support of all delegates, today we are almost completing this session was almost our 45th session of No Thrombosis. So thanks to all our delegates for, watching No Thrombosis on regular basis. Thank you so much. With your support, we also got the award for most engaging scientific platform in any pharma company in India. Thank you so much for your valuable support for No Thrombosis. And today's our chairperson is, Dr. Sandeep Bansal, sir. He's a senior consultant cardiologist and HOD. He's from Department of Cardiology and CTBH Vardhaman, Mahavir Medical College and Safdarganj Hospital, New Delhi, India. Dr. Sandeep, sir, he is very senior international cardiologist, as well as, he done many landmark trials. He has participated as a principal investigator and also published many articles specifically. So from behalf of Emcre, I welcome to Dr. Sandeep Bansal, sir.
Thank you.
Next is our moderator. So our moderator is Dr. Tapish Shahu, sir. So Tapish Shahu, sir, is a vascular surgeon with 90+ years of experience. He completed the MD, DMD, LKCC, and AGSC. He also completed the fellowship in vascular and endovascular surgery. And presently, he is working as the head department of vascular and endovascular science in Manipal Group of Hospitals, New Delhi. So from behalf of Emcre, I welcome to Dr. Tapish Shahu, sir. Next, our moderator is Dr. Naveen Bamri. Dr. Naveen Bamri is a director and HOD of International Cardiology at Max Healthcare Hospital, Shalimar Bagh, Delhi. He is also awarded, with many awards, as well as he has done many, review articles published in the international journals. He is the editor in India on the Indian Heart Journal of Stent Fractures. So, from behalf of Emcre, I welcome to Dr. Naveen Bamri, sir. Our first speaker is Dr. Viduj Jain, sir. He is from Indore. Sir, he is, he's a consultant cardiologist at, at Koitram Hospital and CHL Hospital, Indore. Sir, he is a past national vice president of, Cardiology Society of India, 2008 to 2012. He is also a national convener and hypertension sub-council of Cardiology Society of India from 2016 to 2018. National convener for NIT conference and joint secretary for Indian Academy of Echocardiography. He is also a scientific council member from 2006 to 12, Asia Pacific Society of Cardiology. He is an editorial board member of Asia Pacific Journal, Indian Heart Journal, Journal of Echocardiography. So and also participated in as a principal investigator from the 17 clinical trials and published many articles and chapters, books, almost 31. So abstract reviewer is also there. Was there in ESC proceedings from 2017 to 2022 European Society of Cardiology Conference. So once again, from behalf of Emcre, I welcome to Dr. Viduj Jain, sir. Welcome, sir. And our second speaker is Dr. Navjit Talukdar, sir. Dr. Navjit Talukdar, sir, he has completed MBBS, MD, and DNB in cardiology, and he also fellowship he has done in FESC. Presently working as a senior consultant interventional cardiology and electrophysiology and based in Batra Hospital and Medicine Research Center. He is also, sir, but our Talukdar, sir, has also published many articles in national and international journals. Participated as a faculty in national and international conferences, webinars, and symposium. So once again, from behalf of Emcre, I welcome to Navjit Talukdar. Our third speaker is Dr. Ranjan Modi. Dr. Ranjan Modi is completed, MD, EM in cardio. He is presently working as associate consultant and interventional cardiology at Indraprastha Apollo Hospital, New Delhi. He has trained in Premier Institute of India as well as abroad, and is highly recommended by his patients for exceptional cardiology. So welcome to Dr. Ranjan Modi, sir, for today's program. So with this, this is the agenda we have. So first case discussion by Dr. Viduj Jain. Second case discussion by Ranjan Modi, sir, and third Navjit Talukdar, sir. So with this here, I want to hand over the session to Dr. Sandeep Bansal, sir, for his opening remarks. Thank you, sir. Over to you, sir.
Yeah. Thank you very much. Thank you very much. And I welcome everybody to this No Thrombosis seminar. As you would know, the wonderful thing is that when you know a thing, then you know that there should be no thrombosis. So thrombosis, as we know, in various clinical scenarios, is an important risk factor. And over a period of last several years, we have had newer advancements in this field. We know that there have been improvements in the antiplatelet therapy in the form of coming in of ticagrelor close to about 10 years ago. And we've seen that we've had a wonderful drug in our hand in the form of ticagrelor. We've also had many advancements, particularly in the coronary artery disease field, in the form that we now realize that in several of the patients, it is not just the dual platelet inhibition that is important, but also dual pathway inhibition, particularly beyond the acute phase, the dual pathway inhibition by using the NOACs in combination with aspirin is another very important and exciting area. And what better way to learn about these, the nuances that we all encounter in our clinical practice, the problems that we encounter, and how do we handle them, than to learn, on the basis of case reports. So we have a mix of faculty today. We have a very senior cardiologist in the form of Dr. Exafib20 from Indore. And then we have Dr. Navjeet Talukdar, who's also a senior cardiologist. And we have a relatively younger cardiologist in the form of Dr. Ranjan Modi, and these three guys are going to present their clinical cases. And I'm sure we'll have a very good learning from these cases. So I actually saw Dr. Exafib20 log out for a while. Has he joined in back?
Yeah, I'm here.
Okay. Welcome, Dr. Exafib20. We are all looking forward to your case presentation and the subsequent discussion, please. Over to Dr. Exafib20.
Yeah, thank you very much. Are you able to see my slides?
Yes, we can see. We'd request you to, fine.
Okay, am I audible well?
Yes, you're very well audible, sir.
Yeah, so good evening to all my dear friends. Dr. Sandeep has already introduced the topic, enigmatic thrombosis, how much we can prevent. He definitely told us we are learning a lot, and we have learned in last 2-3 decades, and we have got various agents which are able to prevent the thrombotic events in the body, because we know thrombotic event, whether it occurs in the myocardium or coronary artery or cerebrovascular, it plays havoc, maybe in the form of acute MI or maybe in the form of the acute thrombotic stroke. My patient had both. This is what I am going to present at once. So now, what did we do and where did we have our limitation? Let us learn our limitation today rather than success. So today what I am going to talk is more of limitation rather than my success. So let us see. We all know platelet cascade in thrombosis formation. There are 3 main things: adhesion, activation, and aggregation. So we always try to see the agent which can help and make our life easier. So we know after the rupture of the plaque, there is the exposure of collagen and Wilbrand factor from ruptured plaque, and this is a signal for platelet adhesion at ruptured site. Then there is a secretion of ADP and thromboxane, and expression of ADP and thromboxane receptor to platelet surface and activate limitation. And then we have GP2B and 3A receptor. Why I showed this slide? Because based on this slide, most of the medications are available to us, are working very well for the patient in acute thrombosis. So how can we prevent thrombotic event in a given situation? So available pharmacological agent with evidence is aspirin long term. We have been using it. Antiplatelet activity drugs like clopidogrel, prasugrel, and ticagrelor, as Dr. Sandeep also mentions, one of the very wonderful drugs. In some other situations, we have to use anticoagulants like heparin or low molecular weight heparin. And then we got the additional advantage of newer anticoagulant, that is vitamin K antagonist or NOSE. Then we have things like thrombolytic therapy, particularly for acute thrombosis in the coronary artery, and sometimes in the thrombolytics are also being used in the acute problem of the cerebrovascular collection. So now this is the patient. Let me start with this patient. I went to the hospital in around at 1 o'clock. One patient was brought. He was around 78-year-old. This gentleman was complaining of chest pain of 2-3 hours duration. There was past history of systemic hypertension and angina and effort for 3 years. There was no history of diabetes and he was non-smoker. He was around 56 kg. Past medication included beta blocker, amlodipine, rosuvastatin, aspirin. This patient was seen by me for first time in emergency only. So well, ECG is obvious, had acute myocardial infarction with hyperactivity elevation. Hemodynamically stable till then. Biochemical tests were in progress and TROP-I was positive. So at this stage, we offered to the patient what is the possible best in that institute. So our institute had a plan and option given to them. I was definitely going for angiography at that time. I told you, we'll cancel our patient, we'll tax you first. But relatives were less inclined because they told patient is already 78, 80-year-old and you try thrombolytic therapy, and there were 2 doctors accompanying the patient. So they told, okay, we'll believe in thrombolytic therapy. So well, I had to admit and I had to accept, okay, fine, he's a 78-year-old man and maybe he has multiple other comorbidities, and attendants are doctors, they understand us. They told me, you try thrombolytic and then in case need, you can do PCI. So anyway, so action taken at 1:20 p.m. The patient arrived at 1. So action taken was aspirin, clopidogrel 300 mg as a loading and thrombolytic therapy in the form of anacti plus bolus 30 mg. Weight of patient was around 56 or 58 kg. And he was also given bolus of heparin infusion and followed by infusion of 1000 units per hour. About 2 hours later, I came from the cath lab and re-examined the patient. By then, this patient was chest pain had reduced with stabilization of ECG, his hemodynamics were stable, and his all other investigations were in progress. But anyway, patients were relatively pain-free, so we also felt better. At around 4:30 p.m., I did echo on him and I found his ejection fraction in the range of 46%, regional wall abnormality in the form of anti-wall infarct. There was no MR, no pericardial effusion, no intracardiac mass, clot, anything. So anyway, so this patient I felt he's doing very well. But at around 5:30, when I returned my home, I got call again. This patient has got dysarthria, he had altered sensorium, semi-unconscious and rapidly deteriorating. At that time, he had a motor weakness, but not left-sided, respiratory distress, and there was no external bleeding. I did echo had been done around at 4:30, so I felt that this patient must have possibly bled because he had received aspirin, clopidogrel, thrombolytic therapy, and heparin. So I told my one of neurologist colleague who stays in the hospital. So he said, okay, I'm reaching, and he suspected intracranial bleed as per clinical setting and ongoing medication, which was correct according to him. So well, by the time I reached to the hospital, it took another 45 minutes. So I told them to take this patient to CT scan room. So he sent that patient for CT scan, suspecting he will find the intracranial bleed because the setting was like that. The CT scan of brain was done at around 6:30 p.m. and there was no intracranial bleed. So by the time I reached there, I faced 2-3 situations. Number one, there were a lot of attendants waiting for me. They also felt possibly this patient is bleed up because of the medication which I used. But however, I had 2 doctors who were accompanying and they were still present. They told me whatever has happened, we had accepted that thrombolytic therapy has to be given. But we want to tell one more thing, which I am going to tell you right now. So anyway, I asked for MR, which was done in the next room, and it was large cerebellar infarct. So anyway, so this was neuroimaging done, and he had a definitely cerebellar infarct, as well as there was some mass effect. So patient was still unconscious and very much worsening. So then I reviewed the situation. By then, this patient had no neuro improvement and mass effect was seen, and patient was in respiratory distress, and next echo, no thrombus and rapid neurological deterioration next 3 days. So now I realized what medication I had used. So I had used aspirin. This patient was already on aspirin and statin for last 3 years. And he was given clopidogrel on the top of that. And I had used tenecteplase and heparin bolus and infusion. APTT was really all right. What those doctor told me, sir, we have made a mistake. We did not tell you in the morning. This patient was also given at 10 a.m. prior to this hospitalization in your unit. He was already given enoxaparin, aspirin, and clopidogrel. So it was not communicated at the time of hospital admission by attendant. So what at that time I was just wondering, this patient, what medication total he has received on the day of the event? Enoxaparin 60 milligram, aspirin 350 plus 350, clopidogrel 300 there and 300 with us. Then we gave tenecteplase and we gave heparin bolus and followed by infusion, which everyone would do. And patient was already in aspirin and statin for last 3 years. So now, anyway, enoxaparin I did not give, aspirin I did not give, but clopidogrel we had definitely had given 300 and aspirin 350. So this patient was already on all these drugs given from 10 a.m. to 4:30 p.m. or 5:30 p.m. So you can imagine type of medication received. So type of complication expected in this patient would be hemorrhaging because these are the drugs which are possibly overdosed. Anyway, so why this thrombotic stroke then? All about drugs alone or in combination have potential to prevent the stroke. So what could have been done to prevent this problem? So let us see what is our situation. We know studies which we have done with antithrombotic for prevention of ischemic attack, whether it is Pure Trial or Clarity or Commit, all have definitely told us if you are using aspirin and clopidogrel, your incidence of the definitely stroke will be less. But here we are facing something different. ISI-2 trial also reduced significantly incidence of cardiovascular death and total stroke. But here the situation is a little different. Now let us go to Ascent trial, which had told us if you use TNK30, the ischemic stroke rate is 0.5%, but if you use TNK 40 milligram, then your ischemic stroke can be 1%. Or a patient had received only 30. Now, so what are the possible explanations for this thrombotic event? The first, you would definitely say it may be hypercoagulable state following TNK that is not being utilized by heparin dose. So let's see what is the answer. But this patient has received heparin bolus as well as infusion on the top of enoxaparin. But there are other explanations. There may be gene polymorphism, which can be, in that case, heparin may not be effective. It may be G455A, that is beta fibrinogen, leads to higher fibrinogen level. C6770, that gene mutation can also lead to the increased fibrinogen level, or A12983 that increase the platelet glycoprotein 3A, or methyl tetrahydrofolate reduction, which increases the higher homocysteine level. Now, second most possible explanation, which all of you will ask, LV thrombus, which has caused embolic event. So you would realize, definitely the echo did not show thrombus, however small thrombus can be there. But anti-infarct definitely has more chances of having left ventricular mural thrombus. But mural thrombus occurs by 2 weeks after MI in around 0.6 to 3.7% case. Our case was only 4 to 6 hours only. The risk of LV thrombus formation highest during first 3 months following acute MI. And we have seen after using the lytic therapy and antithrombotic therapy, the LV thrombi rate has come down. A meta-analysis of 2,000 patients in LV thrombus detected by CMR. It also says, even if you do by CMR within a month, this is seen in only 6.3% in a month. So most of the LV thrombi develop in the first 2 weeks of the post-acute infarct, not in the day one, which has happened, which possibly one would ask. So LV thrombus usually occurs after 24th of acute MI, but not as a rule. And serial echocardiography done in around cases of 90% of cases, it was seen only after 2 weeks. So what impact of the drug intervention may have changed the natural history of LV thromboembolic event? Now, what are other possible explanations for thrombotic event? Intraplaque hemorrhage. Sudden expansion of the plaque producing ischemic stroke. We know sometimes intraplaque hemorrhage may suddenly occlude the vessel because of expansion in complex lesion preceding acute ischemic event. The cause of intraplaque hemorrhage is most often secondary to rupture of neovessel, which have been invaded the atherosclerotic plaque like this. You can see intrapleural hemorrhage can be well documented. And if you want to document, it can be this way, it is the pathology, and documentation can be done by imaging. And in imaging, one can see there is an intrapleural hemorrhage. So, well, our patient, it was not possible to send him down because he was very, very sick then. And what are other possible explanations for this thrombotic event? Patient had acute inflammatory state, which we know many patients with acute infarct may have inflammatory state, and we often use large dose of statin and to take care of. A diffuse heightened state of inflammation persists following acute coronary syndrome in vascular system. The circulatory inflammatory cytokine may incite the cascade of thrombosis in the cerebral circulation also. So, well, this patient can have that problem. Then other explanation is multiple vulnerable blocks in the vascular tree. So, well, it can always happen. Unstable carotid plaques are found to be common practice in cases of the ACS, around 23% of unstable angina patient. Emboli may come from aorta and carotid artery, and sometimes catecholaminan activation following MI may also lead to enhanced platelet aggregation and thrombus generation in the vascular system anywhere, not only cardiac, it may occur in the cerebrovascular tree. Then use of thrombolytics and anticoagulant. This medication lies the platelet fibrin protective thrombin layer covering the ulcerated atherosclerosis plaque somewhere in anywhere in the vascular tree, which may suddenly explode and atherosclerosis material into the circulation. So why I try to give all different explanation? In my case, definitely this patient had received all possible antiplatelet and anticoagulant, possibly in higher dose than required, yet there was no LV thrombus, yet patient had a major thrombotic event in the cerebrovascular tree. So possibly, I would ask the panel, what more could have been done to prevent this situation, number one. Number two, I might also like to know what are other explanations which you will think in this particular case can be responsible for acute CVA which proved fatal rather than cardiac status. So hence, whenever we come across this patient's management, there may be relatives also, and they often ask, you gave this medication, patient became serious because of bleeding occurring due to thrombolytics. So we shouldn't accept it easily. We should work up very well patient and try to give the best answer, whatever feasible in that clinical situation. So now may I ask the panelists to give me some direction in this patient? Thank you very much.
Yes, a very great case and very well presented, Dr. Vidyut Jain sir. Very well presented indeed, as a very senior cardiologist of your caliber could have done. There are a couple of points that come to my mind after this presentation. First thing is, I don't think you need so many explanations for what happened. Yeah. We know plain and simple statistics tell us, and I remember having read this, that even in a study of, analysis of over 11 million patients of acute MI, a concomitant ischemic stroke in the American population was present in 1.6% of the patients. So approximately 1.5 to 2% of patients have acute, ischemic event in both the areas, the brain as well as the heart. Though this combination is very less frequent, as I said, it is less than 2%, but it does occur. And this unfortunately happened in your patient. The second point that I noted from the management was the clear fault of the doctors who were accompanying, or the patient himself or the relatives, that they did not disclose that the patient had received the pre-medication that the patient had received. One thing which has been pointed out as responsible for greater complications is the change of the heparin. Like this patient got enoxaparin and then he got heparin. If you remember the studies which compared enoxaparin with heparin, the main factor which was responsible was the change of the drug, rather than either of the drugs being used. So that was the second point I noted. The third thing that I could think of was that many of these patients, age 78, a lot of these patients have undiscovered, intermittent atrial fibrillation. And that is another thing which is responsible for the cause of the problem. Now, as far as the management is concerned, I think you were absolutely on the spot. The only thing I remember in terms of management is that in the STREAM trial, it was noted that if your patient is more than 75 years of age, then you should use half a dose of tenecteplase. And so based on the weight and everything, you use just 30 milligrams, in this patient. So even that dose was adequate. Those are the important points I thought I noted from your presentation. But overall, a very great presentation. Nobody can do anything once you've given so many lytics. Your neurosurgeon will be, reluctant to decompress, even if there is a shift of
midline.
A shift of the midline. So this is a tough case to handle in any situation. I, for one, would say you did the best possible. If there are any comments from Navjeet or from the other two, moderators, I would welcome that.
Sir, one point only. It's a fantastically worked up case.
Yes.
And congratulations, sir. Although I am nobody to judge. But yes, in my limited experience, I think in this patient age group, it is the unrecognized atheroma, especially in the posterior part of the aorta, which is responsible.
Yeah.
Here you see the MCA artery was not involved. The posterior circulation was involved.
Yeah.
Probably something went into the posterior circulation through the vertebral artery.
Yeah.
So while manipulating the catheter, while we manipulate from elderly patients, they have unfolding of aorta. Whenever there is unfolding of aorta, while you manipulate the catheter tends to scrape the posterior wall of the aorta.
Point well taken, Navjeet. Point well taken. But there was no angiography done in this.
We cannot do anything about it. Only thing is we have to keep these things in mind.
Yeah.
Only thing is this.
Yeah.
Right. Great. Tapish, do you have any points to suggest? Or
no, sir. I think a 78-year-old man with all kinds of blood thinners still developing that will be a challenge to everyone who are attending right now, because no intervention was done.
Yeah.
Yes, that is true. Does Naveen or Ranjan have any points to make? Hello, Naveen.
Ranjan sir joined just now. Just now he joined actually.
I'm so sorry, but I just was able to join. This
No worry. We look forward to your talk. And a great case indeed, Dr. Vidyut Jain sir. Thank you so much for presenting such a wonderful case. And next we go to Dr. Ranjan now. Ranjan, are you ready with your case?
Yes, sir. So
yeah,
I will
please,
just...
Yeah, please, the podium is yours.
Share my
start
screen.
your presentation. Yes.
I'm just going to share my screen. Give me 1 second, sir. Yeah, so I hope my slides are visible.
Absolutely.
Thank you. So, okay, I would like to really apologize. I could not join in time. Just stuck in a case. So now what we're going to talk about today is what is the role of NOACs as a case report in acute coronary syndrome and atrial fibrillation. Now, let's start with a patient who was 67-year-old male presented to the hospital with chest pain related to the left arm, also reported with palpitations and shortness of breath. The patient has been a hypertensive and been on amlodipine and metoprolol. The patient also had non-valvular AF, and the patient was on warfarin therapy from a doctor outside with a target INR of about 2 to 3 for the last 2 years. Now, on clinical examination, yes, the patient had atrial fibrillation with a 122 beats per minute irregular, blood pressures of 145/100. ECG also showed atrial fibrillation. There was inferior ST elevation MI with reciprocal changes in of ST depression, lead 1 and ADL. Troponin was raised, CHA2DS2 score was 2. And the patient was admitted for the following symptoms, again, back to us. Now, the patient underwent a coronary angiography. There was a fresh thrombus in the proximal part of PDA. Mechanical thrombectomy was performed and blood flow through the vessel was restored. Now, during this process, the patient was given an infusion of amiodarone. The patient's heart rate was very high. He was in atrial fibrillation. On third day, the patient was discharged on aspirin and clopidogrel, 75 milligrams and 75 milligrams. The patient was asked to continue his old medications. The echo showed there was a normal ejection fraction of 58%. After that, the patient was already on warfarin. Now the question was, do we switch back to Novak as the patient has a non-valvular AF, or we continue with warfarin? So the first question would be, yes, Novak is better than vitamin K antagonist in atrial fibrillation and acute coronary syndrome. I think we all have know this, that yes, there have been multiple studies which have now proven that Novaks in non-valvular AF are better than vitamin K antagonists, specifically in patients with atrial fibrillation and non-coronary syndrome. The next question arises is, in a patient who has an ACS with atrial fibrillation, how do you manage, how do you go about these Novaks? Now, we all know there's a large link of atrial fibrillation, prevalence of CAD in these patients. Prevalence of CAD in patients with atrial fibrillation ranges from about 17 to 46.5%. And also, with both these conditions present, there's a risk of increased ischemic stroke, TIA or thromboembolism by almost 29%, which is a very large number. We know that there are significant challenges in selecting the proper antithrombotic regime. With dual antiplatelets, without Novaks, patients with atrial fibrillation still remain at a high risk of stroke. So we need to combine these antithrombotic agents with antiplatelets, and it becomes a big challenge in patients who have atrial fibrillation with ACS, and what and how to combine these drugs. Now, this is an article which we published in Journal of Indian College of Cardiology, which said that we started looking at non-valvular atrial fibrillation and acute coronary syndrome. What was the present Indian perspective and assessment? Now, we being one of the co-authors in this, we looked at this problem of most of these patients coming in with atrial fibrillation and an ACS. That's how we started to devise an algorithm which we thought was kind of a little practical algorithm where we could help people decide how to use these antiplatelets and novel oral anticoagulation therapies. Now, if you look at this diagram, if you start looking at if the patient has come with an elective PCI or if the patient has come with acute coronary syndrome in the emergency with PCI. Now, suppose the patient has come with elective PCI, we do give a loading dose, we continue with triple therapy, Novaks, and aspirin and clopidogrel or ticagrelol. We do the PCI at discharge at day 1 to 4. We continue with dual therapy. We stop the aspirin. We continue with Novaks and plus clopidogrel plus or ticagrelol. And at the end of 1 year, then we shift over just Novak monotherapy. Now, suppose the patient is coming to emergency. We do give a loading dose of triple therapy. We continue with Novaks. We give aspirin and clopidogrel. We continue at discharge with dual therapy. If the patient is low risk, at 1 year, we shift to Novak monotherapy. If the patient is now on the higher risk, we continue with triple therapy, which is Novaks, aspirin, and clopidogrel. And then we shift over by 3 months to Novaks. We stop the aspirin, we shift to Novaks and a single antiplatelet. And by 1 year, we go to Novaks monotherapy. Now, if we start looking at the approach for new onset atrial fibrillation and anticoagulation. Now, suppose the patient has atrial fibrillation, which is a new onset. How do we give the loading? We give a loading dose of either clopidogrel 600, ticagrelol 180 milligrams, plus aspirin 325, plus anticoagulation, which can be either unfractionated heparin or a low molecular heparin. By day 4, we shift over down back to 75 milligrams of aspirin clopidogrel plus Novaks. By 1 month, Novaks plus clopidogrel. And if the CHA2DS2 score and the Hasblet score is favorable, At 1 year, either we go into high risk for these patients. Now, high risk, we're talking about high risk for acute coronary syndrome patients. We go for NOACs plus clopidogrel. Or if it's just a low risk patient, the patient, let's say, is not multiple stents, the patient does not have diabetes, does not have high risk chances of acute coronary syndrome, we just continue with NOACs alone. Now, most of our patients which end up with us are generally, as the example in the case, are patients who have old atrial fibrillation on NOACs or VKs, and now they've come with an ACS. So in this case, like in our aspect, the patient was already on warfarin, so the patient was already on vitamin K antagonist. We look at INRs. If it's less than 2, we go back, we shift back to the same diagram, we load the dose. On the 4th day, we shift to triple antiplatelet therapy. At 1 month, shift to NOACs and clopidogrel, and then at 1 year, take a call on the high risk and the low risk. Suppose the INR is more than 2. Then what we need to do is switch over to give FFPs, do a radial PCI. We do not give any loading for those patients. So we're talking about suppose in this case, the patient was on warfarin with the INR more than 2, we would have not given any loading dose. We will just go ahead and we restart the NOACs as we have discussed in the previous table at 4 days, at 1 month. This is how we do it. Suppose the patient is already on NOAC. Now what? Suppose the patient is already taking apixaban or rivaroxaban or dabigatran. We look at the last dose of NOAC. Now, if the last dose of NOAC is more than 24 hours and more, we give a loading dose. We go back to the same table where we give the loading dose of ecosprin, clopidogrel. If the NOAC has been less than 24 hours, if suppose the patient took his NOAC in the morning, in most of our BD doses, like apixaban, if he's taken in the morning, he's come in the afternoon, we look at APTTs. If it's less than 2, go ahead, give the loading, go ahead with it. If it's more than 2, again, we do not perform a femoral approach. We go to radial PCIs, we give FFPs, and then get back to loading. So we did give a few recommendations. If I may, I would just like to point out what recommendations we wanted. We wanted, yes, DES has to be the treatment of choice in all these patients with atrial fibrillation and NOACs. Aspirin therapy should be limited to the minimal duration post-PCI, with it being restricted to a very low dose of aspirin. In India, we get 75 milligrams, so we restrict to 75 milligrams. NOACs offer significant advantage over VKs, including less drug and dietary interactions, less routine monitoring of blood works, and greater time in therapeutic range. That they should be the drug of choice in all patients who undergo atrial fibrillation PCI. So, and we know these are things why NOACs have always been at a higher ground than VKs. Specifically in PCIs, because of these things, NOACs have to be in. We cannot give VKs anymore. The chances of bleeding are very high if you give VKs with dual antiplatelets. Potent thyropyridine therapy should be used following stent implantation in the absence of routine P2Y12 testing prior to initiating the antiplatelet monotherapy. Among P2Y12 inhibitors, prasugrel is not a preferred drug. The chances of bleeding are high. Clopidogrel or ticagrelor may be used, but because we have a large amount of literature on clopidogrel, we continue to still maybe give clopidogrel for these patients. We give clopidogrel, aspirin, and a NOAC as a triple therapy combination, because we are still scared about bleeding in most of these cases. Patients on anticoagulant undergoing PCI should undergo routine assessment with intravascular imaging, because we need to know how much thrombotic lesion is there. We need to be sure what is the risk of high-risk lesions, because we need to determine what would be the optimal duration of treatment with DAPT. So suppose the patient has a large thrombotic load, which can be seen on intravascular imaging like an OCT, then we would like to continue these triple therapy combinations for a little while more. If the patient is diabetic, yes. If the patient has multiple stents or let's say osteal placement of vessels, then yes, we need to continue with antiplatelet therapy and then switch over to maybe NOAC monotherapy or a single antiplatelet with NOAC. Now, let us talk about what the NOAC has in the management of ACS. We know dual pathway is important. Platelet aggregation and thrombin generation are both effective and safe strategies in most of these patients. If you look at rivaroxaban, there was an Atlas ACS2 TIMI51 trial, which actually said what is the role of rivaroxaban in patients with recent ACS. This was a trial with 15,000 patients of more than 18 years, all presented with ACS, diagnosed with STEMI, non-STEMI or unstable angina. They were randomized into 3 categories, with rivaroxaban 2.5 twice daily, rivaroxaban 5 mg twice daily, and a placebo. All these were carried out with a mean of 13 months and up to 31 months. Also, primary endpoints being cardiovascular death, myocardial infarction or stroke, and secondary being death because of any cause or MI or stroke. Now, this was a double-blinded trial, which was event-driven trial. When we started looking at these primary endpoints, we were able to see that rivaroxaban did actually decrease the primary efficacy endpoint of death and cardiovascular causes of myocardial infarction and stroke. When we start looking at the occurrence of the primary efficacy point, it actually came down from 10.7 in the placebo group to rivaroxaban 8.9. So we were sure that NOACs do help in reducing the primary efficacy endpoint in all these patients who have AF with PCI. Now, the question was, do they actually help in risk of stent thrombosis as well? And when we start looking at long-term effects, if we looked at placebo 2.9, the chance of stent thrombosis came down to 2.3, though they were not very significant, but there was decrease in the risk of stent thrombosis. We also looked at secondary endpoints, again, from 11 to 9.2. So yes, we were able to establish that rivaroxaban does play a role. Now the question was 2.5 milligrams or 5 milligrams. We started looking at the other two arms, which was the comparison between the two doses of rivaroxaban. The rate of primary efficacy endpoints in patients who were receiving 2.5 milligrams was about 9.1 versus 10.7 in placebo. And in 5 milligrams dose was about 8.8 to 10.7. The question was, when we started using 5 milligrams, there was not a significant survival benefit seen. So even if we used 2.5 milligrams, we were able to get a significant survival benefit in most of these patients with the rivaroxaban. And that's how the concept that, 2.5 milligrams of rivaroxaban is actually better in most of these patients. This is twice daily, most of these patients with AF with PCI. Looking at safety outcomes, there was not significant chances of major bleeding or intracranial hemorrhages. The major bleeding, because of not related to CABG, was approximately high in rivaroxaban group compared to placebo, whereas fatal bleeding with doses was actually non-significant. So, and 2.5 milligrams actually had fewer fatal bleeding events than a 5 milligrams dose. So in conclusion, the trial did actually say that in patients with recent ACS, rivaroxaban 2.5 milligrams reduced the risk of composite endpoint compared to a 5 milligrams or a placebo, and the chances in a 2.5 was much, the chance of bleeding or any risk of fatal bleeding was much lower with the 2.5 milligrams rivaroxaban. So it actually helped in most of these patients who were on ACS with atrial fibrillation. Thank you.
Great. Ranjan, very great, very good case. A problem that each one of us encounters very commonly and very well managed. Very few people have the guts to just do thrombosuction and not put in stents, particularly in the private sector. So appreciate that point, and a good review of literature. Now you were complexed by the fact that this was a patient who was already on a VKA, which kind of confuses a bit. Otherwise, in majority of the clinical scenarios, the science is pretty clear that you give a triple therapy ranging from 2 weeks to 3 months, depending upon whether the patient has a higher thrombotic risk or a higher bleeding risk. So if you have a higher bleeding risk, give for a very short while, 2 weeks, as was done in the apixaban study, and you can prolong it to up to 3 months if your patient has a higher thrombotic risk. Of particular interest are the patients. How do you identify the patients who are at higher risk? That is important. So if my patient is a diabetic, he's elderly, more than 60, if he's got chronic renal failure, he's grade 3 or severer than that, chronic renal failure, is hypertensive. Those are higher risk patients. And you have a choice between using rivaroxaban 2.5 milligrams twice a day or choosing apixaban. A lot of people choose apixaban because the bleeding risk was not higher in the apixaban trial. So all in all, a very well done and well managed case. You also raised the point that clopidogrel has been used. Yes, in majority of the trials, in 90 to 95% of the patients, the second drug in the dual antiplatelet armamentarium has been clopidogrel rather than ticagrelor or prasugrel. Prasugrel is really very few patients. Some 6-7% patients have been on ticagrelor. So you have a choice of using between the two, but because of the practice, we continue to use clopidogrel. So all in all, a great case, well managed. And any comments from Vidyut Jain sir or from Naveen, who may have joined by now, or Navjeet?
Well, I think he has covered very well the topic of using the NEOC, particularly rivaroxaban in the various subsets, lateral fibrillation or coronary syndrome, or what the dose it should be. Definitely, we always believe in the Hasblad score as well as the Chadwick score. Yes. And as you have already highlighted, if the Hasblad score is more, use it for shorter time and use in a smaller dose. And there are studies of a smaller dose also. Regarding the apixaban, well, I have been a principal investigator for Aristotle trial myself. So we know definitely it's a short-acting drugs because it has to be given twice a day. So safety is much better with that. And definitely dose of 2.5 milligram twice a day in elderly population. We have a lot of studies which have confirmed. It's a low risk, and particularly in the renal failure also. These are 2 or 3 advantages which we have learned from Aristotle trial. And I think this particular NOAC has been under use from 2010 onwards. And I think most of people feel safe about it. Thank you very much.
Great.
Exactly. So I think between apixaban and if you look at rivaroxaban, having a slightly higher, maybe a bleeding risk, prevents a lot of patients from going to rivaroxaban rather coming back to apixaban. I think we are very bound in our decisions from the bleeding aspect. Though apixaban and dabigatran have been shown to improve the stroke maximum benefit, but still, apixaban ends up being a little better choice in most of these patients because of the slight higher bleeding risk in rivaroxaban.
Okay, sir.
Navjeet, do you have a point?
Yeah, very valid point. Wonderfully done case. Actually, another point worth discussing is the renal dysfunction. In presence of renal dysfunction, actually, apixaban is a better choice. Yes. So that we know by now. Among all the 3, apixaban is a better choice. By a general rule, just for the discussion case, if there is hepatic dysfunction, we should be choosing dabigatran. If there is renal dysfunction, we should be choosing apixaban.
Right. Great. Naveen, do you have any points to discuss? I think I don't have Naveen on board. So thank you so much. And we go to the last case discussion of the evening. And I'd welcome Dr. Navjeet Talukdar. Please go ahead and present your case.
Thank you, sir. In fact, I'm honored to be able to present before you this case. And straight away, it is quite late. So straight away, I'm going to the case. Am I free to share the screen?
Please, please, please. Yes.
Well, I hope my slide is visible.
Yes, go full screen, please.
Yeah, here am I. So, the earlier 2 cases was quite illustrative, and this case might not be as good as yours. But however, here is an 82-year-old male with history of angina on exertion culminating in recent ACS, impending shock treated elsewhere. He had a sky-high troponin, hemoglobin was 11.9, creatinine was 1.6, he was euglycemic. ECG showed ST depression and anterior leads, somewhat what we see in extensive diseases. There was 40 to 45% EF, and however, no MR, chest X-ray showed PVH, and he had been clinically stable for past 7 days. BP 110/70, pulse rate 100 per minute regular. He was already on beta blocker. Resting SpO2 was 96. But the real shock was while presenting on the process of presentation, we found that he was RT-PCR positive. CT value was 19. HRCT showed 40% lung involvement, and SpO2 at the time was 92 without oxygen. So this case was with due deliberations. We took up the case despite COVID with all precautions. He was going for heart failure, so and angina and bad shape. So we thought that we will take him up on that day only. So after due deliberations, we took up the case. It was in the later part of the evening. The RCA was okay. The left side showed the real crux. There was a bad looking lesion almost starting on the distal end of the left main. It was a shortish left main, and the LAD and circumflex both were diseased and quite severely so. This is another view which showed the circumflex lesion in a more profiled way. So we went on deliberating what is to be done. He was COVID. He was on a bad SES. He was on the verge of heart failure. It is already 2-3 days old, and we decided that we will do something very fast. So both the vessels had to be tackled because it was a distal left main kind of a disease. The challenge was a shortish kind of a left main, which precluded our choice of either a culotte or a mini crush. At the same time, we wanted the procedure to be done as fast as possible because of the COVID situation, and also because his hemodynamics was poor. He would not have tolerated large amount of dye. So wiring and many of the thing was done with minimal amount of dye. In fact, what we did, we half diluted the dye and took a very short injection, something what we call as minimal contrast PCI. So after wiring both the vessels, we went to pre-dilating the circumflex lesion first because it was most tight looking. And this was a 2.5 into 12 mm balloon. Subsequently, we ballooned the LAD, osteoproximal. And this was the post-ballooning result. It is not great, but at least there was no dissection or no other factor was there. Then we thought that what is to be done, and we decided that we'll go for a V stenting. Now there was a question of whether V or SKS. We decided V will be better, and thus we carefully took both the stents. This was 3.5 into 21 and 24 in circumflex and LAD. After due deliberations and on using double mag and other things, we stented both the vessels. This was a stenting with a nice looking V-ish kind of a picture. And just immediately post stenting, this was the result. We carefully looked at whether we did something bad to the left main or not. The result was not that. So we thought that we'll post dilate the lesions and end up the procedure as fast as possible. Here is the post dilatation. Post dilatation was by 4O balloon into 8 at both the vessels. We intended to do a pot, actually kissing. This is the final kissing balloon to end the V properly. And this was the last end result. Now to see the end result as in the standard of these cases nowadays, we thought that we'll do an imaging. And here was the OCT image. On the left side, you can see the 3D recon of the OCT. Stents were more or less well apposed. There was no geographical miss. There was no dissection. There was no stent malapposition. Significantly, the branches were all patent. The coronary artery means the branches were coming out. There was no jailing, etc. And here we were worried how much stent we left in the left main. well, just prior, you could see only 2 struts were there projecting into the left main. So to conclude, distal left main remains one of the holy grails of intervention. Planning, details, hardware selection, guide control is of human importance. Backup mechanical support might help. V-stenting is still relevant in some cases where we need where the speed is important. Here, in this case, we did the entire case in 20 minutes. Imaging OCT IVAS use is imperative. On 6 months follow-up, there was no angina on exertion. Creatinine had come down, maybe for augmented, LV output. ECG, there was minimal ST second echo had improved. The LVID is smaller. He was put on DAPT, aspirin plus ticagrelor plus rosuvastatin and metoprolol, PPI, etc. On 1 year follow-up, that is around 6 months back, dobutamine stress echo was done. It was negative. Near normal LVEF, LVIDD almost came down to normal at 48, and there was no effort symptoms. So this was in a nutshell my case, and I
great
to be,
Great. That is a nice case discussed, Navjeet. And so let us understand from you, in your experience, what have been the problems associated with COVID that you have encountered in the form of acute coronary syndromes? How frequent has been, your patients coming in with acute coronary syndromes with COVID positive situation?
Yeah, sir. To make this answer, I will just, since you've asked my personal experience, my experience is nowhere near you, like you, Dr. Vidyut Jain and all. But then, yes, we, Batra being a, quasi kind of a private and a government kind of a thing, we did have a large volume of COVID patients. Well, in the
just before you continue, may I request the organizers to put us on a multiple screen kind of mode so that each one of us can see each one of us. The presentations are done. So,
yeah.
So, okay. So, Navjeet, you were answering.
The first phase of the COVID, initially there was lot of confusion. What antiplatelets to be used, whether CT is to be done prior of the procedure, whether the cases to be taken thereon, whether thrombolysis is to be done. Lot of confusions was there. So initially we were a little bit reluctant to take up the cases, but we had mortalities. Then gradually literatures came that you need to intervene in these cases as and when need arose. And then we started on the second half of the first COVID impact, we started having more aggressive procedures. This was done in the second COVID era, wherein we almost in our hospital, whoever was bad ACS, we took them up despite the COVID status. Now right. The challenging feature was the respiratory support, because these patients were having some lung involvement, and small quantities of pulmonary venous hypertension would make them very sick, disproportionately sick. Apart from this, the management of the thrombotic state itself was a challenge. How much heparin to give, what ACT is to be kept. You must be remembering that most of the COVID patients used to thrombose, but there is a small subset of COVID patients, around 15 to 20%, who also have increased propensity to bleed. So even if you have very high ACTs, that might be prone to bleed. So a equipoise between the different literatures were obtained. So that
did we do a D-dimer in this patient, and at any point
D-dimer was sent, but then D-dimer came the next day. The report comes after some time. It is not so fast.
No, so what I mean to say is, did you put the patient on a NOAC after that based on D-dimer?
Sir, I am coming to that. So that is a challenge. You cannot keep the ACT very high, but at the same time, just managing on ACT of 200 or this thing is dicey. So as per protocol and the literatures of that time, we started having ACTs near about 300. Then the question is brevity of the procedure. So much stress was left कि आपको कम से कम exposure करना है radiology exposure.
That you did, Navjeet. I'm trying to focus.
I'm just telling you.
Yeah.
So in these cases, what we did, we put the patient on aspirin, ticagrelor, and low molecular heparin for 4 days. Mm-hmm. After that, we put him on half dose of Exafib20, like 2.5 milligram. That was as per recommendation of the Trivandrum guys had come up with a nice looking, algorithm wherein data from New York City Center and other things were taken. Although these were mostly on trials lasting for only 1 year or so, but that was the available data. And they used to classify patients as far as D-dimer and as far as bleeding risk.
Okay. So did your respiratory people put this patient on steroids also?
This patient was not put on steroids because the lung clearance was found in 48 hours. Quite a significant X-ray, this thing was happening. The initial picture of 40% involvement was probably because of disproportionate interstitial edema associated with heart failure, as well as
now your patient is more than 1 year away from the ACS. He's got the patient has renal dysfunction. So would you like to put this patient on an aspirin plus NOAC combination, dual pathway inhibition?
We discontinued the NOACs after 6 weeks.
No, now for the coronary artery disease.
Now for the coronary artery disease, what I have category. Done. No, now it is not a polyvascular disease. So it doesn't fit the Atlas criteria truly. But he is a bad coronary artery disease and high risk PCI. And that is why we put the patient on 60 milligram of ticagrelor along with aspirin for another 9 months.
Okay.
So after 3 months.
Dr. Vidyut sir, do you have any questions for Navjeet?
I think first we must compliment Dr. Navjeet to take this challenging case in the second COVID era, which was very sick period at that time. And most important thing is the anatomy of both the coronary artery was not very easy to handle with short left vein stem, which he handled very well, and he got a good result. Now the most important thing which you have highlighted is the use of NOAC in the post-procedure period, which I think is worth not because of the coronary, but because of the possibly D-dimer was also high, which we don't know. But, so that was also very valid point. Regarding the use of steroid, I have reservation. I will not ask even to use the steroid unless it's very well mandated by the pulmonologist. So other things have been done very well, and steroid I would not have used in this patient unless some documentation for very high CRP or worsening lung condition. This is what I think. Thank you, Dr. Navjeet, to present such case.
So Ranjan, do you have any points to make?
Sir, amazing case. I think doing left main in COVID is.
The one good thing was that he had a pretty suitable case, a 011 Medina for a V stenting. And one does encounter lesions which are suitable for V stenting. It is easier to do and it is very fast. And so very well done in these stressful circumstances. I would request if there are any questions. Go on.
I would like to add a point. We actually had similar patients who developed an MI in hospital admitted post-COVID. I would say we have about 8 or 9 patients. And in those patients, we just stented one patient. Other than that, our approach was kind of a little different. We did mechanical thrombectomy for most of these patients, and we found a large amount of clot which was present.
Yes, that has been a problem with COVID.
Yes, and we put these patients on NOAC and clopidogrel for most of these patients. Most of these, I would say, out of the 9, 1 did stenting. Other than that, 7 out of them who survived actually did well and did not have a coronary event once they were on Novax. And we were giving them a Novax of apixaban 5 milligrams twice a day with the clopidogrel 75 milligrams. We didn't put them on aspirin that point of time because we had not given them any metal. We had just done a thrombosuction. And the vessel looked fine. And we assumed the thrombogenicity is because of COVID, because D dimers were high. They did well for 6 weeks. We shifted them to Novax for another 4 weeks. So 10 weeks, we gave them Novax and then shifted them back to a dual platelet combination because we were still not sure what would be the right approach to it. So we stopped Novax once the D dimers and everything came down and put them on a dual antiplatelet with a clopidogrel plus aspirin 75 milligrams each. And they've been doing fine. 2 of them actually came back. Stress echo was negative. So we assumed, and these were young people. They were about 40, 42, 43 years old. I think we retrospectively, we are happy we didn't give them a stent because most of them made it out. And we assumed that the thrombogenicity was the actual problem which happened. So mechanical thrombectomy actually solved our situation.
Great. So Ravi, may I ask you if there are any questions from the audience that we need to answer?
There are some questions as being already, we have discussed this, all the questions.
Okay.
Yeah.
Okay, I think the time is 9:10.
Yeah, yes, sir. Yes.
I'd hand it over to you for the final vote of thanks and
thank you. So before going vote of thanks, I request RX7 to please show our corporate video if it is ready. So Ankit, can you able to show the video? So till the time Ankit loads this video, yeah, you can play. Yes.
Do you know which Indian pharma company has consistently launched innovative first in India products? Presenting Emcre Pharmaceuticals. With over 500 scientists, we are pioneers in chirality. We have been making a healthy difference to countless families. With cardiology at our heart, we have strived to give you better products always. Chiral products are complex to develop. They are difficult to manufacture, but their benefits make a difference. A difference for your patients, for you. We are proud to launch our latest chiral development, Exafib, our indigenously developed rivaroxaban. Developed in-house, manufactured at our state-of-the-art facility at Jammu. This is a WHO GMP certified facility. We conduct quality checks to ensure only the best is delivered. Exafib complements our chiral cardio portfolio. Exafib, committed to make a difference in anticoagulation therapy for your patients.
So Exafib we have launched 1.5 years before after patent expire, and today we are very proudly says that our Exafib is #1 brand in India. It is most accepted brand because we provide we manufacture this as a chiral brand, and we provide a good quality of Exafib. So thanks to all our all the doctors, those who support and prescribe Exafib. At the same time, we have recently launched the dapagliflozin plus sitagliptin, that is email DAP. Yes, this is a brand we have launched, and we are looking forward the same support and same trust on even email MS also. So with this, I am really very grateful and thankful to Dr. Bansal sir for really wonderfully taking care of this today's no thrombosis program, and Sandeep Bansal sir is managed very well. And also, I appreciate, I am thankful, I'm very grateful for our organization, is very grateful and thankful to Dr. Vidut Jain sir, such a senior sir, and he still agreed to give a very interesting and very unique case, that the issue ensure that it will be really benefit to all our delegates those who joined today. And thank you, sir, Vidut Jain sir, for wonderful presentation. And also, Dr. Ranjan Modi sir, even he was busy today, when his busy schedule, he has taken a time and he joined and he's presented his case. And a wonderful discussion specifically on NEAF. And definitely it was very helpful for all delegates to join. And Navjeet Talukdar sir,
always, we can trust on his, the international cases, what with the presence, and even more the delegates always look like to see Abjit international case always. So thank you, sir, Abjit sir. Thank you so much. So once again, thanks to Tapish Sahu sir, for his wonderful insights, specifically on all the cases. Once again, from beyond from Emcre, I would like to thanks to all our post director, moderator, and speakers. So thank you, sir. Thank you so much.
Thank you.
Good night.
Thank you, sir. Bye.
Thank you. Bye.